You can go live now.
Hello, good afternoon, doctors. On behalf of Ritu Healthcare, I, Dr. Prashant, welcome you to this webinar on PPH prevention with Carbetocin. At Hetero Doctors, as you know, we market products in multiple therapy areas like in gynecology, dermatology, gastropulmonology, and orthopedics. We have a very strong R&D background, which is why we try to develop products keeping patient benefit in mind. Our endeavor is to improve patient compliance and ultimately hope to improve clinical outcome. We have developed NSAID patches, reverse treatment patches to improve patient compliance. Gynecology, obstetrics, and IVF is an important therapy segment for us at Frenza. Apart from conventional tablets like Didropal and Milotin, we have market products for vaginal health like Feminora and Paletra, as you know. We also market a vaginal film, lactic acid film under the brand name Silero. Recently, we have introduced Carbetocin under brand name Carbiact for PPH. We all know that PPH is a potentially life-threatening condition and requires intense management. To speak more about PPH prevention with Carbetocin, we have Dr. Ritu Santwani with us. Dr. Ritu Santwani is MD, FICOG, FIAOG, AMR COG at ART Singapore. She is founder at CEO 360 Degrees Healthcare Studio. Madam is Director Staff Shamwell Women's Clinic at PTBC. Co-founder of MAN, board members SWWS. Madam, apart from gynecology and obstetrics, also is an infertility specialist, sexologist, and cosmetologist based in Koregaon, Pune. Dr. Ritu Santwani has more than 24 years experience in women's healthcare. Once again, a warm welcome, Dr. Ritu Santwani. Welcome and all yours. Thank you.
Thank you, Dr. Prashant, and thanks again to Hetero for inviting me here. So first of all, a very, very warm welcome to all dear friends, those who have joined in this afternoon. Actually, Hetero wants the webinar from 5 to 6, but I thought this is actually the OPD time. Again, from 5 p.m. we are going to start our OPD. So I suggested them that will be much better, that from 3:30 to 4:30 we can do. So before I start sharing the slides, so friends, today we are going to discuss regarding about the new molecule, the Carbetocin. See, we are using this molecule from last 2 to 3 years, and we are getting very, very good results. Still, a lot of doctors, I am having running a lot of academic groups, a lot of doctors are joining there and asking me that this query also, that madam, why this Carbetocin is superior to oxytocin? Is it like that we can use this for the induction of labor also? When this has to give? Earlier, the product which was coming, that has to be only refrigerated like oxytocin. Now the molecule is coming in the heat stable form, so, and it is coming in the pre-filled syringe form also. So a lot of advantages of this, of the Carbetocin over the oxytocin. Now I am starting sharing my presentation. Later on, if any questions, friends, we can discuss. Friends, today our discussion is focused on the medical management of the PPH. So I'm discussing only about the medical management, not about the surgical management. Surgical management is still itself is another entity. So yeah. I think slides are visible.
They are, ma'am.
Okay. I purposefully kept the background slide for this because we all are aware that the history of the Taj Mahal and how this lady has died due to the severe PPH. So that's why I focused this background slide of her. Thank you, Dr. Prashant, for such a nice introduction. Friends, my all presentations always start with Mata Durga Stuti. Ya Devi Sarvabhuteshu Chikitsa Rupen Sansita Namastasei 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 Namo Namah. So friends, today we are going to discuss that what's new in the medical management of PPH, or what's the changes in the PPH management from then and now, what we are using these days. So now first I will show some statistics. What's the incidence of the PPH in India? So friends, as we all are aware that PPH is the leading cause of the maternal deaths in India. Prevalence in India is 38%. PPH accounts for up to 56% of maternal deaths in India. we can see by this pie chart, the causes of the maternal mortality in India, we can see among this, the major chunk is by this red color, the 38% is by the hemorrhage. Then we can see the unsafe abortion, obstructed labor, sepsis, and hypertensive disorder. These all account for this. So this PPH accounts for 1/4 of all maternal deaths worldwide. PPH accounts for 35 to 56% of maternal deaths in India. So these are the common causes which we have just discussed. So friends, as we all know, the PPH is defined as a cumulative blood loss more than 500 ml following vaginal delivery or more than 1000 ml following cesarean delivery, or any amount of the blood loss within 24 hours after the birth, evidenced by a rise in pulse rate and falling BP. So as we all aware, the primary PPH within the first 24 hours of delivery, while the secondary PPH from 24 hours to 12 weeks after delivery. We all are aware of this. And we all are aware regarding this 4 T's of the PPH, the tone, trauma, tissue, and thrombin. Of this, the tone is very common, around 70% incidence due to tone, atonic uterus. Trauma is lacerations, hematomas, inversion, rupture. In the tissue, the retained tissue. And then again, the T is constant for the coagulopathies. So I'm being an infertility specialist, lot of patients, what I'm delivering is a twin and triplet. So atonic uterus is very, very common entity in our scenario. So I switched to this Carbetocin. I think now it's almost 2.5 years I'm using this drug. So the most common cause of the postpartum hemorrhage is uterine atony, which results from poor contraction of the uterus after the childbirth. So the risk factors for PPH, as we know, friends, atonic uterus, the prolonged use of oxytocin, high parity, chorioamnionitis, GA, over-distended uterus in the cases of the twin or triplet pregnancy, polyhydramnios, macrosomia, fibroid uterus, the multiple uterine fibroids or the inversion of the uterus, excessive umbilical cord traction, short umbilical cord, fundal implantation of the placenta. Then coming to this genital tract trauma, the episiotomy, cervical, vaginal, perineal laceration, uterine rupture, operative vaginal delivery, precipitate delivery, retained placental tissue, retained placenta, placenta accreta, previous uterine surgery, incomplete placenta at delivery, or the coagulopathies, as we all know, in the cases of the preeclampsia, amniotic fluid embolism, or some abdominal bruising, fetal deaths, abruptio placentae, this all has been reported. So friends, now coming one by one, first I will give you the little bit scenario about the PPH, and then we are focusing on all the studies which are focused on the Carbetocin. Just a second, yeah. Lata, मुझे disturb हो रहा है. So risk factors of PPH, the prolonged labor, grand multipara, augmented and precipitated labor, history of PPH, over-distended uterus, macrosomia, twins, polyhydramnios, operative delivery, chorioamnionitis has been reported. So friends, here we can see the blood loss can be estimated by weighing of compressors, visual estimates, collecting devices, and shock index. So friends, here we can see that more than 500 ml, the normal condition, more than 1000 ml is severe PPH, more than 2000 ml is the massive hemorrhage. So now what is the practice prophylaxis of PH? So here we can see the improvement of the health status of mother. The hemoglobin should be more than 11 g%. Identify the high-risk women. Plan for institutional delivery. Strict vigilance of all women in third stage of labor. Practice the active management of the third stage of labor in all. Examination of afterbirth should be a routine. Exploration of the uterovaginal canal following difficult instrumental destructive delivery. So now, what is the recommendation by the WHO? The WHO recommends the active management of the third stage of labor for the prevention of PPH. So friends, here we can see For this, it includes the bimanual uterine massage, simultaneously uterotonic agent administration. So prophylactic administration of uterotonic agents is identified as the most important component of active management of the third stage of labor. It reduces the incidence of PPH nearly by 50%. This is very important. So the PPH after cesarean deliveries has become an epidemic in India. What the studies have shown by 2019 December, that a record 300% jump in the last decade. The incidence of PPH are high in cesarean sections, 6.75% compared to the vaginal deliveries, where it has been reported 2 to 4%. So PPH is more likely compared in the vagina to section compared to vaginal deliveries. In this, what the studies have shown that approximately 36% of the cesarean deliveries are complicated by PPH. So it's a common practice to give the uterotonic drug following the delivery of the neonate during the cesarean section. The studies have come in 2019, the international consensus statement on the use of the uterotonic agents during the cesarean section, like oxytocin, carbetocin, recommends for the routine administration immediately after delivery of the fetus during cesarean section to prevent the PPH. So how we are using this drug? So administration of uterotonic drug agents are very essential during the cesarean section in the third stage of labor following vaginal delivery to diminish the risk of PPH and improve the maternal safety. So here, the uterotonic drugs, what we are using, as we all know, friends, the posterior pituitary hormone and analogs is the oxytocin and carbetocin. Then among the ergot alkaloids, the ergometrin, methylergometrin, prostaglandins and analogs PGE2, misoprostol and carboprost has been used. So among this, the oxytocin and carbetocin are the first line agents. And this ergometrin and this prostaglandin analog are the second line agents. So these days, the drug of choice is the carbetocin. Now I will show the some studies that how this drug is superior compared to oxytocin. So, yeah. Earlier, by 2019, the oxytocin was considered as a golden standard treatment for the prevention of the PPH. But now, what are the problems with this? This drug has a short half-life. Oxytocin is 4 to 10 minutes. The duration of action is 15 to 20 minutes. So we have to give as a continuous IV infusion to attain the sustained uterotonic activity throughout the surgical procedure and immediate postpartum period. It causes the receptor desensitization. It is used for inducing or augmenting labor, may desensitize the oxytocin receptors, thereby impairing the oxytocin's post-delivery effects on the uterine contractility. So now, variation in the dosage, various international bodies and trials have been used regarding the different doses of the oxytocin, but there is no consistency in the dosage regimen, which results in the errors into the administration. So a lot of studies have come. So in addition to the labor-inducing drug, the oxytocin we all know has been used in the past decades by the dairy farming sector, where the properties as a lactation enhancer has been used to increase the milk production amongst the milk animals and increase the size and speed up of the ripening, conversion of the starch to sugars in the process in the fruits and vegetables. This I found once I going through the PPTs, I found this some good studies, so I thought to incorporate in this. So then the studies have come, and from the Ministry of the Health and Family Welfare, the notification dated in April 27, 2018 that prohibited the private sector companies from the manufacturing and distribution of oxytocin for domestic use. Only now one company from the Karnataka, KPL, has gone the monopoly for manufacturing this oxytocin. So now what's the need of the hour? Need of the hour is the drug should be longer acting, single dose administration. There will be no variation in the dose regimen, devoid of repeated administration, ease of one-time administration, superior efficacy or similar efficacy as that of oxytocin, devoid of receptor desensitization, and superior side effect profile over the oxytocin. So here, friends, we can see the carbetocin is actually a synthetic analog of human oxytocin with some structural modifications we can see here. So this structural modification here, we can see, friends, these structural modification increases the half-life of the carbetocin, thereby prolonging its pharmacological effects. So now how this drug acts, it acts acting through oxytocin receptors, which causes the uterus to contract. The drug should be oxytocin, uterotonic, anti-hemorrhagic. So this is for the regarding the mechanism of action, how this drug is acting. This carbetocin selectively binds to oxytocin receptors. IPT promotes the release of calcium from the intracellular rhythmic contractions of the uterus. So I'm going to show one small video.
A postpartum hemorrhage, or PPH, is an obstetrical emergency affecting an estimated 10% of all live births. It is the most preventable cause of maternal death. The uterine arteries pump 500 to 700 milliliters per minute into the site at which the placenta is attached to the uterus. After birth, this blood could potentially flow into the uterine cavity and be lost from circulation. In most cases of vaginal delivery, however, the myometrium contracts firmly, compressing the blood vessels and thereby reducing blood flow. A cesarean delivery can increase the risk of a PPH developing due to the insufficient contraction of the uterine musculature. Carbetocin specifically targets uterine atony. Carbetocin is administered as a single intravenous injection. After injection, carbetocin is carried rapidly to its site of action, the smooth muscle cells in the uterus. Here it binds to oxytocin receptors. In this way, a signaling cascade is started. As a result, the smooth muscle cells of the myometrium start contracting regularly. This causes the leaking blood vessels in the uterus to be compressed and to constrict. The overall effect? The bleeding stops and uterine involution is furthered.
Mr. Vijay, my voice is coming clearly because electricity has gone and lot of thunder showers are here.
We can, ma'am.
Okay, yeah. So now this is showing the carbetocin versus oxytocin. The half-life of carbetocin, we know, friends, 40 minutes. It is 10 folds higher than oxytocin, 4 minutes. Duration of action of carbetocin is longer than IV and IM oxytocin. So friends, all the studies have shown that a single IV bolus injection of carbetocin was at least effective as 16 hours of the continuous oxytocin infusion. Carbetocin need no repeated administration, no dose variation. Single dose of carbetocin is found to be effective in controlling the PPH, unlike oxytocin. So this drug has to be considered superior over the oxytocin with respect to its pharmacokinetic parameters and single dose administration. So studies have shown that this drug in the list of the uterotonics for the prevention of the excessive bleeding after the childbirth. The studies have come from the FIGO guidelines in June 2021, also for the support of this drug. So friends, here we see that how this FIGO recommendation for the prevention and treatment of PPH, we all know. Earlier, we all are using this oxytocin as 10 international units per ml IM or 5 international units slowly within the first minutes after the delivery. for the prevention, and 0.2 mg of the methergine IM with the first minute after the delivery, and the misoprostol. If oxytocin is not available, then 600 microgram orally, or we are giving the sublingually or rectally also. Now, once this for the PPH treatment also, we all know the oxytocin, misoprostol, methyl ergometrin. But these days, the drug of, yes, symptometrin also, we have used lot of symptometrin. I have used lot in my PG time. So yes, then now we are using this carbetocin 100 microgram intramuscular or IV over the 1 minute. We all know, we all have used this carboprost injection also, 250 microgram intramuscularly, and sometimes we had given this intramyometrically also. So the guidelines have come from the FOXI also, that for the management of the prevention of the cesarean sections. Earlier, what we are using, I have just shown that slide. So yeah. Then it is in AICOG 2019, the carbetocin for the atonic PPS, the paper was presented. The total duration of a single injection of IV carbetocin in uterine activity is about 1 hour, hence only the single dose is sufficient. It has a potent uterotonic effect on the pregnant and immediate postpartum uterus and no effect on the non-gravid uterus. The bioavailability of the drug is around 75 to 80%. So now what are the studies have come that what are the limitations by the oxytocin are being targeted by the introduction of a new molecule of the carbetocin. Here again I am showing what are the main points. Friends, as we all know, the limitations with the usage of oxytocin are shorter half-life, 3 to 17 minutes, and we have to give continuous IV infusion necessary to achieve the sustained uterotonic activity. मला अजून पण आठवण आहे, म्हणजे ऍट द टाइम ऑफ आर पीजी म्हणजे आपल्याला ते मॉनिटर करायसाठी एक माणसाची ड्यूटी असायची की पेटोसिन का ऑक्सीटोसिन का डोज ज्यादा नहीं हो जाना चाहिए, तो 1 person should be there, 1 junior resident should be posted here to observe that. And for the elective cesarean section, a slow 0.3 to 1 international unit of the oxytocin over the 1 minute, followed by the infusion of 5 to 10 international units per hour for 4 hours is required to women with PPH. So friends, we all know what are the side effects which has been reported with oxytocin: the hypotension, nausea, vomiting, dysrhythmias, STT changes, pulmonary edema, and severe water intoxication with convulsions has been reported in some patients. So now coming to the pharmacokinetic of this new drug carbetocin, we know after intramuscular administration, the peak concentration are reached in 30 minutes and the bioavailability is 77%. Regarding this, breast milk detectable in the very small amount, and the excretion is excreted less than 1% of the injected dose excreted unchanged by the kidney. Terminal elimination half-life 33 minutes after the IV and 55 minutes after the intramuscular administration. So a lot of studies have come regarding the support of this. The WHO recommendation for the use of the uterotonics in the prevention of the PPH. So friends, here also we can see the oxytocin, carbetocin, misoprostol, ergometrin, and we all know the symptometrin also. So carbetocin is actually introduced and recommended by the WHO as an effective uterotonic in 2018 only by guidelines. So carboprost is not recommended by WHO. We all are aware earlier when this carbetocin was not available, sometimes we are getting a very flappy uterus due to severe PPH, and sometimes in the twins or triplets. Yes, so I had used in lot of patients the carboprost also. Then friends, this is the guidelines, the special PIGO recommendations for the management of the PPH. This has been presented in the March 2022 only. Regarding the dose of this carbetocin 100 microgram IM or IV for the prevention of PPH, we can see this. Then For this, the lot of studies has been done for the prevention of the PPH. So I will show, yeah. So here, friends, a lot of studies they have done. This study has been presented in 2018 only. So they have seen that with the use of this Carbetocin 100 microgram and comparing with this 5-unit slow IV by this oxytocin. So yeah, sorry. So they have shown that how this drug is superior compared to this oxytocin. So a lot of studies has been presented that how this drug is effective in reducing the blood loss and no need of the additional uterotonic agents. With this oxytocin, it has been reported up to 27.1, while with carbetocin only 9.1. Similarly, if the blood loss will be less, the chances of the anemia will be less. So this IV carbetocin is considered to be more effective than IV oxytocin for the prevention of atonic PPH among the singleton pregnancies with at least one risk factor for PPH. So a lot of studies have come by the Actor and Jasmine that the efficacy of carbetocin in comparison with the oxytocin in the active management of the third stage of the labor following the vaginal delivery. They have done the RCTs. So they have compared all the parameters. I will just take this. So they have concluded by this that this drug has been more better and good alternative to oxytocin in the active management of the third stage of the labor in vaginal delivery. So here I want to clarify, friends, this drug we are using for the prevention and for the PPH and not for the induction of the labor. So yes, still lot of studies are there. Once I'm going through for making the presentation, lot of studies have been presented in the all the part of the world. This study is presented in the Africa. So then the study has come which has been compared this carbetocin, oxytocin and misoprostol. So this also has shown that the no significant differences regarding the side effects between the oxytocin and carbetocin. Side effects are reported highest amongst in the misoprostol group. We all know. Yeah. So yeah. Again, the studies have come which has done the comparative study of both of this for the twin pregnancy in the patient undergoing the cesarean section. Then they have found that the no need of the additional uterine drugs with carbetocin is very less compared to the oxytocin. And yeah, they have shown, the studies have concluded that the single dose of carbetocin appears to be more effective than oxytocin for several hours on the uterine contraction and though preventing postpartum hemorrhage in multiple pregnancy patients undergoing elective cesarean section. So studies have shown that carbetocin versus sublingual misoprostol plus oxytocin infusion for the prevention of PPH at the cesarean section in patients with risk factors. They have done RCT. So they have found, the study has done more than 380 patients, and yeah, these all studies have shown that the carbetocin is superior over the combination of oxytocin plus misoprostol with respect to the all efficacy parameters with almost similar adverse side effects. So again, there are a lot of studies has been presented in the favor of this. So these studies have also shown that it is a longer acting oxytocin, so no need for any additional other uterotonic drugs. Then while the comparison with this methyl ergometrin, this is shown the reduction in the postpartum blood loss and more safety in the side effects of the drug than compared to methyl ergometrin maleate. Then the study has been supported by the Cochrane also, significant improvement with less blood loss for the prevention of the PPH. So friends, this drug is being used for the prevention of PPH, not for the treatment of PPH. So the studies has shown the single dose of the carbetocin is efficacious and safe on the maintenance of the uterine tone and the limitation of the blood losses peri and post-operative period. Carbetocin was able to reduce the pain perception during the post-operative days, improving the quality life of the woman. So, again, one important point here I want to emphasize that due to longer half-life, the single injection is sufficient, and compared to the oxytocin, which needs the repeated injection or the perfusion for the several hours. So studies have shown that in some patients, it is the we can see it should be considered a valid option in the management of the third stage of the labor in patients with hypertensive disorders of pregnancy. But friends, we once we are dealing with these kind of patients, we always explain the patient all the pros and cons regarding the drug also. So now, what are the recent studies have come for this? So this study has been come, which has done the comparative study amongst the twin pregnancies which underwent the cesarean section. So this study has also shown justice. I'll show the main. So in the studies have shown that adding of the 100 microgram of the carbetocin to regular uterotonics decreases the total blood loss and the risk of undiagnosed PPH. It has also reduced the need for the bottle compression and the IV fluid supplement. So the studies have shown of this drug in the cesarean sections for placenta previa and accreta also. So studies have shown that this carbetocin can reduce the requirement of additional uterotonics or procedures in cesarean deliveries for placenta previa also. So studies have shown that this drug is more effective than misoprostol in preventing the incidence of atonic PPH in patients performing the elective cesarean delivery with severe PPH. Studies have shown, friends, that it has to be more, this drug has been more effective in the hemoglobin reduction, platelet reduction, and calculated estimated blood loss. Other advantage that oxytocin is that it has lower negative effects on the urine output than compared to oxytocin. So lot of data has come, no carcinogenicity has been reported by this. So a lot of studies regarding the safety profile also for the drug has been reported. So earlier what we are using, if the pitocin is not working, we all are using is the carboprost. So carboprost is now considered to be second line agent in the PPH, while carbetocin is the first line. So, and it is recommended by the WHO, and while carboprost not, and no such side effects has been reported. And it can be given in the patients of the asthma also, while for the carboprost, we all are aware we can't give in the patients of the bronchial asthma and associated with severe vomiting, diarrhea, and other incidences. So it has been proved to be superior over the oxytocin and other uterotonics with respect on the prevention of PPH, estimated blood loss after delivery, need of additional uterotonic agents, decrease in hemoglobin levels, need of the blood transfusion, perception of pain, and side effect profile. So now one trial was done is the champion trial, also the famous champion trial for the carbetocin. As for the progesterone, the PRISM trial for this carbetocin was the champion trial. It has been done across the 23 centers in 10 countries, including the India. So these are the centers we are getting the list in the net. So it has been proved to be non-inferior to oxytocin with the ease of the single dose of the administration. So yeah. So a lot of studies have come regarding the safety of this drug and the usage. The single 1 ml dose IV as a bolus injection slowly over 1 minute after the delivery of the infant. So friends, we have to remember this point. Yeah. So it has been considered superior over the oxytocin for the prevention of PPH, blood loss after delivery, need of additional urotonic agents, deviation in hemoglobin levels, and need of blood transfusion, perception of pain, side effect profile. So while compared to this ergot alkaloids, prevention of PPH, blood loss after delivery, need of additional urotonic agents, need of blood transfusion, and better side effect profile. So thus this drug is superior over this. And now earlier it was available once we have to keep on in the fridge. Now the heat stable form is also available. Pre-filled syringes are also available. So earlier once the drug has been launched, to how to explain the staff or the junior doctor how to dilute this. But now these days, so a lot of companies have come with this pre-filled syringes also. So this is the most effective urotonic and most awaited urotonic drugs, which has been, yeah. Now, what are the contraindications with this has been reported? Yes, not in the pregnancy and labor before the delivery of the infant. It should not be used for the induction of labor in the patients who are hypersensitive to carbetocin or oxytocin, not in the patients of the epilepsy, serious cardiovascular disorders, and hepatic or renal disease not allowed to be used. While with this drug, the breastfeeding is having a no problem. So regarding this drug interactions, among this we have shown, the studies have shown the severe hypertension has been reported with when oxytocin was given 3 to 4 hours following the prophylactic administration of a vasoconstrictor in conjunction with caudal block anesthesia. Enhances the BP enhancing effect. Inhalational anesthetics like halothane and cyclopropane. Arrhythmias has been reported for oxytocin during the concomitant use. So studies have shown that the systemic orgasms and what are the very common and what are the common side effects. So here, friends, we can see a very less of the side effects has been reported with this. So coming to the conclusion, all the pregnancies are at the risk of the PPH, even if there is no predisposing factors are present. A very famous quote, once I preparing the slides, I found this. So this is really obstetrics. We all know anytime which patient is converted for the cesarean section or which patients we have planned for the cesarean section, we can do the normal delivery. So for this, the 3 Ds in this is the delay in recognizing and seeking the help, delay in the transport and reaching the medical facility, and delay in receiving the adequate treatment. And 4th D is, of course, the death. So friends, this is a very nice, if you can say, animation I have found. Once the pregnant patient is coming, some patients are coming to us that, ma'am, last time was a massive PPH, lot of delivery, and throughout this pregnancy, or they are also very much tense. What happened will be this time? Is it again post-delivery? I have to go for so many blood transfusions or some surgery. So this drug is comparatively very good, has come. So which a lot of studies have shown, friends, that all support in the favor of this. So now these I have put some questions because I have taken for this Carbetocin once talk. So many questions have come from the audience. So I tried to keep that questions in this PPT form. So yes, for the lactating mothers, this drug can be given. Very minimal amount can be transferred. Means lactating mother, we are giving just on the 3rd stage of the the delivery of the baby. So no problem with the breastfeeding. So yes, it can be given along with the if the patient has used the oxytocin for the induction of labor, then in that case also we can use. It is not contraindicated for the asthma patient, yet it can be given intramuscular or IV. No need for the re-administration of this drug. One dose is sufficient, and this drug is not to be used for the induction of the labor. Yes, now what's its interaction with the tranexamic acid? So no such interaction has been reported with the tranexamic acid. Studies have shown that this drug gives better results with the misoprostol. Studies have shown that nothing like that neonatal jaundice by this drug, and studies have shown that it causes in some patients the tachycardia and hypotension, being analog to oxytocin. So cardiovascular effects caused by the oxytocin cannot be overruled. So we are not preferring in the patients of that. Similarly, the history has come that in the patients, and studies have come, not the history, sorry, studies have come due to antidiuretic effects leading to hyponatremia, and which can exacerbate the epilepsy. And the studies have shown. Just a second, Dr. Pramod, just a second. One of my patient is having an urgent bleeding. Just a second, I will take this. So this patient can be administered to the patients who are allergic to oxytocin. No, it cannot be used. So with this, I will wind off the presentation. Only give me a second. We will take the questions. I think the phone is disconnected. Okay. So I will.
There are a few questions, but I'm not taking your time because you've been having an emergency. One thing I want to say, you rightly said that in obstetrics, it is very, expect the unexpected.
Yeah. Very true. Very true. Yes. 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 Listening.
Now, what I want to say is that can we say that you can use
only a minute, Dr. Prashant? Just give me only a minute. Only a minute. Yeah, Dr. Prashant. Sorry for that.
Obstetrics is full of emergencies, madam.
Yes.
We were dreading our posting in obstetrics because we know it's only emergencies. Can you say, madam, that use carbetocin prophylactically in every delivery?
I'm using because see, I'm the infertility specialist, so I am delivering most of the patients with the twin and triplet pregnancies. So anyhow, this drug has become the drug of choice now these days. Even though the patient is delivering a singleton pregnancy also, so no need for the monitoring. Otherwise, we have to train a lot of the residents or the nursing staff how you are giving the pitocin. Dose ज़्यादा नहीं होना चाहिए, drip rate proper चलना चाहिए. Otherwise, the hypotension will happen. So these days, due to very means I can say almost no side effects, so this drug has become a drug of choice. Our science is like that, more and more inventions, then we have to go for the newer drugs, not for the older drugs.
Well, if the patient has got oxytocin fatigue, obviously carbetocin will not work, I suppose.
No, sorry, again come.
Patient is not responding. Suppose
If patient is not responding because the receptors are the same, because the mode of action is the same. So, but if your patient is not responding, or if, I have seen in this 24 years of the practice, I've seen 3 patients allergic to oxytocin. Only 3 patients, but 3 patients I have seen. Patient. Yes, then in that case, friends, not to give. If any history of the allergy or reaction to oxytocin, then in that case, don't give this carbetocin also. Carbetocin, I think it's very, very good because of the first very important point, the single dose we have to give. Second very important point, no need for such monitoring. That means less staff and less headache for us also how to monitor. Third very important point, we can give this very safely to the patients of the asthma also. So a lot of patients are coming these days of the asthma also, unko bhi de sakte hain. And fourth very important point, as in some patients of the PPH, once with the pitocin or symptomatrin also, it is not controlling. In that patients, we usually give this carboprost injection. So in that patients, the nausea, vomiting is the major side effects. Yes, and of course, no to the asthmatic patients. So, like these side effects are not there. And patient is also happy these days. If less the injections, less the monitoring,
That's what
they can go easily. Yeah.
one thing, madam, do you think cold chain, not requiring cold chain is a major issue in our country?
Earlier, though, I think it was that, but now, though, I think a lot of companies have come with the heat stable.
No, what I'm saying is that because oxytocin requires cold chain. And
Yes, of course, of course.
Yeah, that's a big advantage.
Because
we know
India is being a tropical country, so it is very, very important. Every time म्हणजे तुम्ही लेबर रूम मध्ये सांगायचे सिस्टरला पटकन तुम्ही पितो ऑक्सिटोसिन काढून ठेवा, विसरू नका, फ्रिजच्या जवळ ठेवा काढा. So that is also very, very important. Yes, that is one very, very important point that especially in the PHCs also, because some patients are referred from the PHCs to insert triplets. कि वहां पे या तो ट्विन प्रेगनेंसी तो कई बार उनको डायरेक्ट मेजर हॉस्पिटल में भेज दिया जाता है कि नहीं यहाँ पे कुछ प्रॉब्लम होगा. So this is the drug which they can use also. Means I think, and we have to train lot of PHC staff also, ANMs also, that this drug is very, very good.
And what would you suggest, madam? There's one question. In patients with recent placenta in second trimester MTP, what could this be used, or what is your clinical judgment on this?
Okay.
Recent placenta in second trimester.
Again comes retained placenta in the second trimester. In the second trimester, we can use no problem. We can use. I have used in some patients also. Yes, but you have to monitor very properly. Either you are doing the manual removal of the placenta, or in one patient in the January also, my second trimester patient, she aborted and she has got the retained placenta. So we had done the manual removal of the placenta, given this drug, but we have done under ultrasound guidance. Means we have checked at that time only, so no problem.
Finally, PPH have to go
but here, Dr. Prashant, I want to specify because these all things should be done in the hospital with the proper facilities, not in the smaller place. Yeah, that is also very, very important point. Yeah.
These PPH patients eventually have to go for surgical management, despite all these drugs available.
No, I think now the incidence has become very, very less. Now, once we are using the drugs earlier, though any the patient can be turned to the any complication. So with every patient, we are always prepared. But now with the advent of these such good drugs, the chances of the towards going surgery, internal iliac artery ligation, or earlier the subtotal hysterectomy. When I passed out 24 years back in our residency, we have done a lot of patients are coming for PPH with the septic abortion and subtotal hysterectomy. अभी तो मुझे याद भी नहीं आता, मुझे सोचना पड़ेगा मैंने कब किया था subtotal. Yeah.
That's a very interesting question. If we use oxytocin in antepartum phase, can carbetocin postpartum phase?
Yes, you can use. I have shown the slide also. You can use also, no problem. You can use. You can use. आंख बंद करके आराम से पेशेंट को अगर ऑक्सीटोसिन से कोई प्रॉब्लम नहीं हुआ तो कार्बेटोसिन से भी कोई प्रॉब्लम नहीं होने वाला है. बल्कि आपके लिए अच्छा है, आपको पीपीएच मॉनिटरिंग करने के लिए अपने स्टाफ को नहीं रोकना है, खुद नहीं रुकना है. यू हैव टू गिव द सिंगल डोज एंड विद द सिंगल डोज द रिजल्ट्स हैव कम. पीपीएच के लिए वी हैव टू कीप द ड्रिप एंड वी हैव टू मॉनिटर दैट हाउ वी आर टेपरिंग द डोज आल्सो. सो दिस इज very, very, very good advantage of this drug. Yeah.
So, theoretical question. Suppose if you have given carbetocin and the patient is not responding fully to our expectation, what would you use? Or what is what
no, then in that case, if you ask me my personal, then in that case, I will give the carboprost. Though, yes, we give along with this ondansetron and loperamide, all the side effects. Even though in some patients, yes, after giving carbetocin also not responding, symptometrin also not responding. Yes, I of course try with this carboprost, especially the intramyometrial. Even and tight packing also. Tight packing also does the bimanual compression, also does the very, very good results. Even though if it is not responding, then we have to go for the surgical procedure.
At that point of time, we don't worry about side effects,
Yes. Yeah. Very true.
Is symptometrin available in India? No, I suppose. No, is it?
No, I don't think it is available now. But even though if we want to use, we are giving by mixing the one pitocin and one methergin injection.
That is correct. That is
Yeah.
correct.
Earlier, the Novartis was giving the only one company which is giving the symptometrin injection. So now, I think from last 3 years, I have not used oxytocin only. Means I am using constantly this carbetocin only.
This is a very interesting question. This is my question.
Huh.
Now, carbetocin has so many advantages over oxytocin, but why is carbetocin not picked up to that level of oxytocin?
I think now, Dr. Prashant, is still the lack of awareness. We have to educate. मैं आपको बताती हूँ, when I have taken Dr. Prashant the first lecture for this carbetocin, that are the questions actually had come by the participant doctors. So I have clicked the pictures and yeah. So and because still the lot of lack of awareness and to the doctors also, because सबको क्या लगता है कि ये भी जो हो रहा है ये इंडक्शन ऑफ लेबर के लिए यूज हो रहा है ऑक्सीटोसिन कार्बिटोसिन, तो बहुत सारे लोगों के दिमाग में एक ऐसा ही लगता है कि कार्बिटोसिन इज आल्सो यूज्ड फॉर द इंडक्शन ऑफ द लेबर. So we have to actually, yeah.
Maybe some education is required on that.
Yes, yes. Lot of education, lot of programs if we can do now. So this drug, now if we are having a miracle drug with us, so we have to use that drug. You have to use the advantage of that drug.
Madam, thank you so much. It was a wonderful session. We like your videos and animation. I mean, you to add it to this.
Thank you.
So much once again. If there are any more
Thank you.
questions, we'll come back to you. Thank you.
Okay. Thank you, Prashant. Dr. Prashant.
Thank you.
Chalo. Bye. Bye to all dear friends. प्रशांत सर आले पुण्यात तर या माझ्याकडे.
नक्की.